Hello, welcome everyone. I'm Sharon Dudley Brown. I'm an assistant professor here at Johns Hopkins University. Specifically, I see patients in our inflammatory bowel disease center. And so in creating my talk for today, which is really to present to patients and their families, I tried to think of the things and the questions that I get from patients. And what are some of the things that I spend a lot of time with when I'm in my office with the patient talking about IBD. So I put them into 15 things people with IBD should know. So these are in a little bit of an order in terms of my sort of perceived importance, but I also had to make it flow a little bit. So number one is really no one knows what causes IBD. Patients still ask all the time, but nobody really knows. So there's a tiny amount of genetic risk. So if you have a parent or a first-degree relative, you are more likely as a child to develop the disease. However, keep in mind that 85% of patients who get a diagnosis of IBD have no family history. In addition, we have learned over time that there's an environmental effect. So IBD is an autoimmune disease, and so if you know anything about autoimmune disease, a lot of this has been impacted by the environment. So we know that the rates of IBD increases when that area or country becomes more westernized, or if that person moves to the United States. And we also know that IBD has some changes in the intestines that can be initiated by certain things. So on my slide I have aspirin, ibuprofen, as well as GI infections. So many times the trigger when people first initially get their diagnosis of IBD and get sick, sometimes it's triggered by an actual infection. The infection goes away, but the body perceives the inflammation or that, that there is something there. That's that autoimmune notion, and so it keeps creating the inflammation in the area. So medications are good. So in general, I like patients to think that medications are a good thing. Patients frequently perceive medications to be bad things, but most IBD patients need to be on a regular medication, whether it's a daily pill, a weekly or bi-weekly injection, an infusion, but most patients need to be on regular medications, meaning they take it around the 12 months of the year, year after year. The only medication that's an exception is steroids, because they're only a bridge to another medication. I'm going to talk more about that in a few minutes. So really, the risk of not treating the IBD is worse than the treatment of the IBD. Treating earlier, we know, improves outcomes. So this is especially in Crohn's disease, that the earlier the treatment, the better outcomes, meaning less surgeries, which my colleague is going to talk about in a few minutes. The goal is really remission. In addition to remission so the patient feels better and doesn't have symptoms, our goal is also eliminating the inflammation that's causing the symptoms in the first place. Medications may be, the patient may be required to take multiple medications in order to achieve this improvement in the inflammation. And the other tip is that we always continue medications in pregnancy. This slide just shows the impact of stopping medications. So being good about taking your medication, again, whether it's prescribed daily and the patient takes it daily, or however it's prescribed, is really important. So this slide basically says that over time, stopping taking the medication, you can see that the risk of a flare-up or not being in remission really increases. So adherence patients, 89% chance of remaining in remission after 2 years if they take their medication regularly. Those that stop, you can see, have a flare-up. So we know that adherence is really the key. So this is a slide that was done from a study from the Crohn's and Colitis Foundation of America, and they asked patients directly, why do you not take medication? And the number one, as you can see on this slide, says too many times per day, but there's also it's inconvenient, too many pills, or I don't have symptoms. So, right, people feel better, they stop taking their medication, but we know this is problematic. So, number 4 is that this notion of steroids are really a bridge, but you have to know where you're going as you start to cross that bridge. So this slide phrases it more as a, if you start a rescue therapy, for example with steroids, you need an exit strategy. So where are you going to go? And that's when frequently we start patients on medications in the class of biologics. Number 5 are the issues around narcotics. Many patients with both Crohn's or ulcerative colitis have abdominal pain. However, narcotics, for many reasons nowadays, are not the best medications. Here on this slide, I outline why in the GI area, narcotics are really not helpful. So narcotics are associated with increased infections, abscesses, which are infections inside, and fistula, which I'm going to talk about in a few minutes. And narcotics are associated with worse outcomes. So when we, at a hospital center, the hospital looks at, right, who's sick and who dies. And what's the number 1 is narcotics and steroids. So narcotics can actually worsen inflammation, and they can also make the bowel slow down, which isn't helpful when we're trying to treat the disease and figure out the status of the GI tract. So the bottom line is to avoid narcotics. Number 6 is urgency, and this really focuses on treating the location. Urgency really comes from inflammation that's in the rectum. Whether it's Crohn's disease or ulcerative colitis, if the disease is in the rectum, the patient is going to have urgency. So a normal rectum can stretch to hold the stool. If it gets inflamed, it doesn't stretch well. And if it's inflamed, it's hypersensitive. So even a little bit of liquid makes it feel full. So the patient feels like they have to keep running to the bathroom. Hence that notion of urgency. So this is really best treated with a topical therapy or a local therapy. So some sort of therapy that's put right on or into the rectum, usually a suppository or an enema. Number 7 is about fistula. And what a fistula is an abnormal connection between 2 areas. In this case, it's 2 organs that don't normally connect. And fistula occur when inflammation is present. And usually in the GI tract, it also occurs when there's pressure present. So the key is inflammation, right? So if we can get rid of the inflammation with taking medications, then most likely patients don't develop fistula. However, if there's a lot of inflammation in an area, the patient can develop a fistula. The picture here is actually of a buttocks, cheek, and you can see a fistula on the top part because there is sort of this bypass area, bypassing probably a rectum, and that is coming to the outer wall. It can be internal, so it can one part of the bowel to the other part, or to the bladder, or to the vagina. Number 8, how do we treat fistula? Because these are not fun for patients to develop. So the important thing to remember is we do have treatment. However, we really want to try to prevent them by really managing that inflammation. But if they occur, we typically maximize our therapy, again, targeting the inflammation. I would say 99.9% of patients need to be on a class of medication of the biologics. If they're already on it, we usually increase the doses in order to drive that inflammation down. Our surgeon is going to talk about cetons, I believe, that helps to wick and drain the area to prevent developing an abscess. And then also we need to remove any stricture, that's a narrowing, if it's present, either through surgery or by dilating it endoscopically. Steroids work, but steroids increase the risk of infections, increase risks of strictures, diabetes, cataracts, obesity, weight gain, and contribute to anxiety and depression. The goal should be that you're not on steroids more than once a year, and preferably never, if that's possible. And my next slide is really to talk about osteoporosis. So steroids can cause rapid bone loss, and it can occur in the first 2 months if you're taking a daily steroid. This is happening, but the problem is the patient doesn't know it's happening. This bone loss is difficult to reverse. We do have some medications, but they're not perfect in and of themselves either. We usually recommend patients take calcium and vitamin D, but sometimes there are prescription medications that can be given to help prevent or reverse the bone loss. And this is all detected through using a DEXA scan or a bone scan, which is a radiology test. Number 11, Crohn's is worsened a lot by smoking. So for some reason, which we don't know the exact mechanism, a patient who has Crohn's disease who smokes has worse symptoms than the patient who is a non-smoker. We know that treatments are significantly less effective. So we can give you 5 different medications and be on high dose of those medications, but they're just not as effective as in the patient who is a non-smoker. In addition, if patients smoke, those patients have more surgeries than the equivalent non-smoker. And stopping smoking is more effective than changing therapy in many instances. This is really only particular for Crohn's disease because the opposite seems to be true for ulcerative colitis, in that patients who have a flare-up of their ulcerative colitis, if they were a smoker, if they do smoke, the flare-up or the inflammation goes away. So we see this a lot in patients who quit smoking in their 40s and 50s, and within 9 to 12 months, those are the patients sometimes are diagnosed with ulcerative colitis because smoking at that time was protective probably for a number of years, and when they stop smoking, there's inflammation. Again, we don't know the exact mechanism of all of that. Number 12 is about an infection. So Clostridium difficile, or what we call C. diff, is a bacteria that infects and inflames the colon. Causes a lot of watery diarrhea, just like patients who have inflammatory bowel disease get. It occurs more in people with decreased normal bacteria, so patients who recently used any antibiotics, and it's much more common in people with IBD than the average population. So what we do is we want to make sure that any flare-up is not a cause caused by C. diff infection before changing therapy or adding steroids. And the picture on the right here is a picture of a colon which is infected with the C. difficile bacteria. 13 is about, we have a couple ways of sort of predicting the future. So this is an area where there's a lot of research being done right now. We know for a number of years that there are biomarkers which may have been run when you were first diagnosed with IBD or somebody was thinking about it. So some people use them to help diagnose IBD, but it's really the best to help predict who may have more severe Crohn's or ulcerative colitis. So those are the patients that we counsel and tell them that we think you're going to have a fairly severe case of IBD. Therefore, trying to make sure that we get rid of that inflammation and that we really monitor that inflammation quite often over time. There are inflammatory markers that are in the blood. So C-reactive protein and sedimentation rate are inexpensive blood tests. They're not specific to Crohn's, colitis, or any IBD, but they are markers of inflammation in the body. So they can be helpful in saying that a patient is in a flare-up and having inflammation. And then it's a predictor in that if the markers of inflammation are normal and the patient, is feeling well, then there's really a less than 5% risk of flare in the next year. So that's how it's helping us as a clinician predict how well the patient will do. And we usually use all of that also in combination with the colonoscopy. And what's a little bit newer in the last few years is a stool test or stool marker of inflammation, which is a fecal calprotectin. And we can use those to help see if the patient is in a flare-up and also monitor that. So it's sort of the poor man's colonoscopy that we can use sort of on an urgent basis to look at inflammation in the colon. Number 14, IBD outside the gut. I find that patients really are never told about this until they either have an episode of extraintestinal manifestations or if they come to clinic with me and I talk about it with every single patient at every visit. So most of these extraintestinal manifestations correlate with gut inflammation. And these can be seen in the liver, the skin, joints, or eyes. And basically it shows how IBD is a very systemic disease, so it's not just the gut that's involved. Some of these other organs are involved as well. We treat these with medications that we use to control the gut inflammation, so frequently it's the same medications that we use, and sometimes we escalate the dosing on current medications in order to manage these extraintestinal manifestations. And then finally is the notion of health maintenance. So I find that patients, many patients with IBD are young and they don't have a primary care provider, but they really need to have one because they need to have a access point for not only if they do possibly get sick, but they need for things like vaccines. So they need to have a central home and make sure they get regular checkups. So vaccines are really important. IBD patients who are on biologics can't have live vaccines, but we actually don't have a lot of live vaccines around the country today. And they definitely need to get a flu vaccine annually to help prevent any flu. Patients need to get cancer screenings either by their primary care provider or going to a specialist. So things like pap smears in women. Certain medications can increase the patient's risk for skin cancer, so they need to see, those patients would need to be referred to a dermatologist on an annual basis. And then behavioral health is really important. Again, whether it's through the primary care provider or referring to a behavioral health specialist can be helpful. Anxiety and depression is much more common in IBD patients than it is in the general population. Whether it's cause or effect, looking certainly at the symptoms are enough to cause increases in anxiety and depression in these patients. And the Canadian studies show that the rates are about 30% for both anxiety and depression in patients, higher in Crohn's patients than in ulcerative colitis patients.